In this video, we'll talk about the supraventricular tachycardia. The definition of the supraventricular tachycardia is pretty simple, which means that any tachyarrhythmia or any tachydysarrhythmia that is arising above the level of bundle of Hess. So if we look at the heart here, we have the two atria and the two ventricle, and there is a fibrocartilaginous membrane in between with a small opening for bundle of Hess to exit from the AV node and goes to the bundle branches, the right and the left bundle branches. So any tachycardia that has a focus of origin above the bundle of Hess, this is called supraventricular tachycardia. It's the other thing that is usually confusing medical providers. It is often used synonymously with the AV nodal reentry tachycardia. Okay, and this is really very important because AV nodal reentry tachycardia is actually a form of the SVT. It is the most common form of the SVT. But we use them interchangeably. Either we say like this patient has SVT or AV in RT. They are the same. Okay, but when we study the pathophysiology of all the supraventricular tachycardia, we will find that supraventricular tachycardia is not a diagnosis. It's only a description that the patient is having a tachycardia that is originating above bundle of Hess, but we have to know what type of tachycardia the patient is having. And actually, it could be anything. It could be regular or irregular. Or is it originating from the atria or from the AV node itself? So these are very important topics. The other thing is usually the supraventricular tachycardia, because it is originating above the bundle of Hess, and this is following the normal pathway of the electricity spreading in the heart, it is usually a narrow complex tachycardia. But this is not always. Why? Because some patients will have bundle branch blocks. Bundle branch block itself will make the electricity move slower in the heart, making the QRS complex wider. Or the patients may have apparent conduction that make the conduction slower as well. Or there is an accessory pathway making the normal flow of the electricity slower. So it could be a narrow complex tachycardia or a wide complex tachycardia, and we don't use the complex width to classify the supraventricular tachycardia, because any supraventricular tachycardia could be a narrow complex or a wide complex according to the structure of the heart itself. Number three is sometimes we describe the supraventricular tachycardia as paroxysmal. And when we say paroxysmal, that describes any SVT with abrupt onset and abrupt offset. And actually, this is characteristically seen only with the re-entrant tachycardias that involving the AV nodes. Again, if a patient developed an SVT and it abruptly started and abruptly stopped by itself, it is more likely to be of AV node origin. Okay, now we will talk about the classification of SVT. That's fine. Okay, now let's have a look for a case of SVT. Okay, let's look at this patient. This patient almost is having a tachycardia of like 300 or something like that, because like between the QRS complexes here, this is a rhythm strip, and you can see that there is a small 1.2 large squares between the two R waves. So the heart rate may be like 180 or something like that. And if you look at the QRS complex, it is a narrow complex tachycardia, but this is not the rule, okay? So any tachycardia that originates above bundle of Hess is by definition a supraventricular tachycardia. Okay, let's talk about the classification of the supraventricular tachycardia. The classification actually depends on only two things, either the site of origin and the regularity. The site of origin, it could be coming from the atrium itself, the atrial wall itself, or the AV node itself. And regularity, it could be regular or irregular. So either we can say that the patient has SVT that is atrial regular or atrial irregular. Characteristically, when we say AV node origin, if the origin is the AV node, it's almost always regular. We don't have AV node irregular because the AV node is firing at regular interval. Okay, so we don't have this combination. We can say AV node and irregular at the same moment, meaning that the atrial fibrillation, which is always irregular, cannot originate from the AV node itself. Okay, just to stress it out, the classification based on QRS complex width is at all non-helpful because any of them can come as a case of narrow complex or a case of wide complex, according to the presence of pre-existing bundle branch block or apparent conduction or accessory pathways already in the heart. All right, that being said, guys, so we can actually divide the SVT into three major categories. Either it's originating from atrium and it's regular, or it's originating from the atrium but it's irregular, or it is originating from the AV node, and by definition, it will be regular. Now, if it is regular and atrium, you have to think about these five. Either the patient is having sinus tachycardia, or atrial tachycardia, or atrial flutter, or sinus node reentrant tachycardia. The reentry is within the sinus node, or inappropriate sinus tachycardia. These are the only regular atrial tachycardias. All of them is actually an SVT. Okay, so if the patient is having an irregular tachycardia and it's originating from the atrium, it could be atrial fibrillation or atrial flutter, but with variable block, because if the AV node is variably blocking the beats, the tachycardia will appear as irregular. Or it could be multifocal atrial tachycardia that is seen with hypoxia and COPD patients. Now, if the patient is having AV nodal and it's regular, you have to think about three: junctional tachycardia, or AV nodal reentry tachycardia, which is the most common, or AV reentry, atrioventricular reentry tachycardia. We will talk about all these in separate videos. Each one will have a separate video to diagnose the patient with one of these SVTs. But the take-home message, all of them are considered as cases of SVT.